It was a rainy evening. While I was just leaving my OPD, I got a call from a very tensed cataract surgeon stating that he had an eventful phacoemulsification and he had referred me that patient. So I waited for a while and saw the patient. On examination, the rhexis margin was good, there was some retained lens matter and I could see vitreous in the AC. So basically it was a case of an aborted phacoemulsification. The visual acuity was only hand movement because of the excess lens matter in the optical axis. So hence, the plan of action was to remove the lens matter and place a secondary lens, preferably in the sulcus. So with my 25 gauge system, I started the case. I tried to remove the lens matter with a Simcoe cannula using the same phacotunnel the surgeon had made. Since the lens matter was extremely sticky, I made the other two ports and used a cutter to aspirate the remaining lens matter. Suddenly, while aspirating the lens matter, I could see a shiny reflex. So I looked a little carefully with some magnification and I was surprised to see a hanging IOL in the vitreous cavity. The IOL was hung or was tucked in the lens matter. So once I finished aspirating the lens matter from the pars plana root, the support of the IOL went away. And there the IOL went down in the vitreous cavity. So being a posterior segment surgeon, the IOL was basically in my zone now, so I was not very skeptical about it. So I went inside and cleared off the vitreous. So now, after doing a good core and a peripheral vitrectomy, I could see one of the haptics of the IOL was already broken. Now my aim was to induce a good posterior vitreous detachment and then remove the IOL from the other haptic junction through a scleral tunnel via the pars plana route. So now, since the PVD is very well induced, the next step is to make a pars plana entry. So I remove one of the ports and make an entry along the supratemporal quadrant via a MVR blade. So once the entry is done, I go in with an IOL holding forceps and I hold the IOL via the optic haptic junction and try to remove it. But as you saw while removing it, the other haptic also got broken. And now what is remaining is just the optic. So to make sure the optic doesn't go down, I hold it with the help of a one-tooth forceps and gently remove it. Oh, the poor crippled IOL. I was so relieved. So now the next step was to suture the port, that is the entry that was made, and clear off the remaining vitreous. My aim was to put a secondary IOL in the sulcus because the rhexis margin was very well intact. So I used a 3-piece IOL and injected it in the anterior chamber. Once it was in the anterior chamber, I dialed it with the help of a max grip forceps and I placed it in the sulcus. Once it was well settled in the sulcus, I used pilocarpine to induce meiosis. After a good anterior chamber wash, an air bubble was placed and the remaining ports were removed. On 1 week follow-up, the patient reported to the local cataract surgeon happily with a vision of 6/9 with a cylindrical correction. The fundus was absolutely okay and the patient as well as the cataract surgeon were delighted. Thank you very much for watching.